Academically. We are headquartered in Australia, and we are an EdTech aim to help the healthcare professionals to excel in their careers and life. And it is the brainchild of Dr. Akram. Over the past 15 plus years, sir is helping healthcare professionals in numerous, with the guidance as well as helping them to migrate to different countries. And we are not only catering to the pharmacy domain. Apart from the pharmacy domain, there are other verticals in the medical industry, like for the medicos, for the dentist, for the lab technician. So we are catering to all such domains and helping the healthcare professionals to achieve their dream. Having said that, on the screen, you can see all our seasoned faculties, and today we are really happy to have Kiran on board for the masterclass delivery. And if you can see, all of them have gone through the similar set of journey. Now, recently, KAPS examination got changed to the OPRA format. However, in terms of the content, in terms of the overall preparation strategy, it will almost remain same. And the faculties that, they are, the journey they have gone through, we are bringing the best onto the table when it is about the preparation. Having said that, we have Dr. Alok as our academic head for the pharmacy courses at Academically. Sir is also having 14 years of professional experience, and he is a PhD in pharmaceutical sciences. And all the pharmacy-related courses are, getting built, getting revamped under his guidance. Followed by, we have Dr. Rini Sharma as the academic head for the medical courses, and all medical-related, courses that are being developed under Academically's umbrella, that is being under the guidance of Dr. Rini. Now we will start with the presentation, and I'll just pass on the mic to Dr. Kiran. Kiran, over to you, and I'll help you out with the presentation.
Hello, everyone. So I'll be taking this topic for you: angina pectoris, pathophysiology, and pharmacology. So we know that being pharmacist, pharmacology is very important for us. The drugs, their indications, mechanism of action, adverse effects, interactions. So we'll be primarily dealing with that. But of course, before starting anti-anginal drugs, what do anti-anginal drugs do? Obviously, they relieve the pain of angina. They relieve the attack of angina, right? So before starting that, it is very important for us to understand that what angina is, right? What angina is. I know since all of you are must be coming from a pharmacy background, majority of you would be knowing what angina is. But before that, I'll also give you a brief introduction what angina is. So let's start it. So anyways, the annotation.
Sorry, Shiv. Kiran, can you see the annotation option wherein you can maximize your screen? Just beside that, there is a pen sort of option. You can just click onto it. Yes.
Really not able to see it.
Shiv, could you please guide in that case? So if there's opinion of you can guide. I can do it too.
I've done the full screen.
Can you please try hovering to the on the screen? Just press your mouse and you can do that.
Can't really. Okay. So angina, right? Now we know the physiology, the pathology of the heart. What is heart doing? What is the function of the heart? the function of the heart is to pump the blood. So the blood comes into the heart from the right side. Everyone must be aware of the physiology of the heart. So the blood comes from the heart to the right side. I'm trying to still find it, but because that makes it very convenient for me.
I think even we can continue. I will just share a screenshot in the meantime.
Okay. Okay. So what happens is that when the left ventricle, the blood, the deoxygenated blood, it comes from the, can you get to the heart slide, Shoini? The one where is the physiology of the heart and the heart is there. It's the 9th or the 10th slide. Further. Yeah, over here. So this is the right side of your heart. The deoxygenated blood in the heart comes on the right side. And then it goes to the oxygenation for the lungs. And then the oxygenated blood, the fresh oxygenated blood, that comes into the heart from the left side. So this is what is normally happening in the blood, in the body. Now, from where the deoxygenated blood is coming? From superior vena cava and from inferior vena cava, right? So inferior vena cava means that this nerve or this blood vessel, it collects the blood from the inferior part of your body and it brings it on the right side. Superior vena cava means that it collects the blood from the superior part of your body and again it brings it to the right side. From the right side, the deoxygenated blood, it goes to the lungs for oxygenation, and after oxygenation it comes to the left side. From left atrium it goes to the left ventricle, and then left ventricle it pumps the blood through the aorta into the entire body. So left ventricle, as you can see, it's the major pumping organ, so it needs a lot of blood to do that action. So when left ventricle is contracted, the entire blood goes to the aorta, and from aorta, it goes to the entire body. But this heart, to do this action, to do this systole, to do this contraction, this heart also needs energy. And from where is it getting energy? It needs ATP, it needs energy, and that energy is coming from blood. Dr. Sabha says that there is no sound. Please confirm that if I'm audible. Am I audible? Okay, thank you. So from aorta, the blood is pumped to the entire body. Now this left ventricle, you can say that this left ventricle, behind this, next to this left ventricle, there is a coronary artery. There is a coronary artery from aorta. From aorta over here, there is a big artery, which is a coronary artery. And this coronary artery supplies to this ventricle, this left ventricle. Coronary artery is there on the aorta, and this supplies to the left ventricle. And this coronary artery is known as conductance vessel. This is known as conductance vessel. And from this coronary artery, multiple small branches are arising, which go into the left ventricle, and that are known as resistance vessel. So there is a one big artery, coronary artery, which is responsible for supplying the blood to the heart. In order to pump the blood, in order to pump blood into the aorta to rest of your body, it needs energy, it needs blood. Where is this left ventricle getting blood from? It is getting from coronary artery. Coronary artery is present on the aorta, and it has multiple small vessels which are known as resistance vessels, which protrude into the left ventricle, and they supply the left ventricle with the blood. Now let's say this coronary artery has some blockage. So we need to go at the back. Shoini, we need to go at the back. More back. To the first slide. So let's say that this coronary artery has some blockage. It has a plaque, right? This coronary artery, which is supplying to the left ventricle, it has a plaque. Plaque is a blockage. It is made up of fat. So it is blocking the conductance vessel. So if it will block the conductance vessel, what will happen? You can write it in the chat box. What will happen? That ultimately the resistance vessels will get less blood. And when the resistance vessels will get less blood, the left part of the heart will get less blood. When it will get less blood, it will pump less blood, right? So this is basically happening in angina. There are three types of angina: classic stable angina, unstable angina, and prinzmetal angina. The classification of the three types of angina is based on the type of the blockage, right? So what happens in classical angina? In classical angina, there is a atheroma. There is a atheroma in the conductance vessel, in the main coronary artery, in the main coronary artery. So what will happen? That this coronary artery will give less blood to the heart. Although the resistance vessels are normal, the small branches which arise from the coronary artery, they are normal. But what is the point? If there is less blood in the coronary artery, so even the resistance vessel will get less blood. So what will happen? The wall of the heart will have transient ischemia. Transient ischemia means that it will have a shortage of oxygen supply, blood supply. So what will happen? Just imagine that your heart is just like a father, right? He is just like a father who needs to give blood to all the parts of the body. So just like a father, you know, he gets meal for all of his kids. Your heart is the one who's providing with the meal to all the kids. Now, your parts of the body, they are the kids. But in order to pump efficiently, the heart also needs energy, right? So father also needs energy, heart also needs energy. So that energy is provided by the blood. So if your heart will receive less blood because of the occlusion on the artery, because of some atheroma in the artery, because of spasm of the artery, or because of formation of a blood clot in the artery, due to any reason, what will happen? It will give less blood. But it wouldn't know that the supply to him is blocked. So in that situation, he will exert more. When he will exert more, what will happen? That during that exertion, there will be a shortage of the blood supply, because the heart would be pumping so much that it will receive, that a chest pain will arise, right? So because of the exertion of the heart, because of increased force of contraction, there is a pain which is known as chest pain, which is arising. Now that chest pain is arising because the heart is exerting more. Why is it exerting more? Because it needs to meet the demand of the body, but it can't meet the demand of the body. Why it can't meet the demand of the body? Because heart is getting less blood. So it gets less blood, it pumps less blood. But during that pumping, it exerts more because it is trying to fulfill the needs of the body. And during that pumping, during that exertion, a chest pain arises. Now, what happens in a classic stable angina? There is an atheroma. There is an atheroma. So let's say atheroma means that 30% of the artery is blocked, right? 30% of the artery is blocked, but the 70% of the artery is blocked, but the 30% is open, right? So now if the artery is 30% open, so heart will receive less blood. Heart is receive less blood, but that less blood is sufficient to meet the demands of the body when the body is at rest. When the body is at rest, that 30% blood is sufficient to meet the demands of the body. But when the body is exerting, when the body is in a state of high emotion, when the body is exercising, then that 30% is not sufficient. Why? Because when you are exercising, or when you're running, or when you're doing any sort of activity, your body needs more energy. Your heart needs more oxygen to pump, to contract. So at that time, the pain which is arising is angina, and that is more common in, that is known as classical angina. So classical or stable angina is the one which comes with some exertion, which comes with exercise, which comes with an emotional stress, right? This can happen. This happens during exercise. This happens during emotions, high emotions. This happens during some sort of activity. It does not comes at rest. So this means that this kind of angina is predictable, because usually people, like if you and me who are not having any sort of blockage, when we will exercise, what will happen? That the demand of our body will be fulfilled. We will be consuming more oxygen. But when a person who is actually vulnerable to angina, when he will exercise, it is actually predictable that he will have angina during that exercise. So what do doctors suggest? That a person who is actually vulnerable to classic angina or stable angina, they tell him to take the tablet before exercising or before carrying out any cardiac activity. So let's just read it. Attacks are predictably provoked by exercise or emotion and eating, and subside when the increased energy demand is withdrawn. The coronary obstruction is fixed. Blood flow fails to increase during decreased demand despite local factors mediating dilation of resistance vessel. So what does this basically means? That there is a atheroma. There is atheroma in the artery. Now, when there is an atheroma in the coronary artery, what will happen? That the blood supply would be reduced. However, that blood supply is sufficient when the person is at rest. But when the person is exercising, when the person is highly emotional, what happens? That supply becomes less. And at that time, your heart needs more energy. So what can happen? That your heart will exert more. So this kind of angina, which occurs with emotion, with exercise, with eating, or with when the demand is increased in the body, is known as classic or stable angina. However, it subsides when the triggering stimulus, like let's see that this kind of angina, which is happening with exercise, if you remove that stimulus, if you remove that stimulus, that angina will subside, right? So this is triggered by emotions. This is triggered by exercise. Once the stimulus is subsided, the attack of angina will subside. Now, in this case, there is atheroma in the coronary artery. If there is a spasm of the coronary artery, then that type of angina is called as vasospastic angina or prinzimetal angina. Like there is the spasm of the coronary artery. The coronary artery is spasmed, is narrowed due to genetics or due to any XYZ factor. If there is spasm of the coronary artery and then the blood supply is reduced to the heart, that is known as vasospastic angina. Thirdly, what is unstable angina? Unstable angina is the one in which instead of atheroma, there is a clot. There is a thrombus. There is a clot formation. Why do clots form? Clots usually form as a result of atheroma. The formation of clot, the formation of thrombus is pretty sudden, right? It's very sudden. So if instead of atheroma, there is a clot, that is known as unstable angina. If there is a spasm of the artery, that is known as vasospastic angina. If there is an atheroma, that is known as classic stable angina. However, in all the three cases, the blood supply to the coronary artery is reduced. And when the blood supply to the coronary artery is reduced, heart is pumping more to meet the demands of the body. When heart is pumping more to meet the demands of the body, what will happen? It will exert more. And when it will exert more, during that exertion, chest pain arises. And that chest pain is known as angina. So why is angina basically happening? Because there is an imbalance between the demand and supply. Your heart is exerting more, but the supply is less. That is why it is exerting more. And it is not able to meet the demands of the body. So eventually there is an imbalance between the supply and the demand. And that leads to the chest pain, which is known as angina. So let's move further. As I've discussed, that what is unstable angina? Unstable angina is the one in which there is a platelet deposition. So you know that thrombus is a blood clot. It is formed by the deposition of the platelets. Once the plaque ruptures, what is plaque? Plaque is made up of fats. Atheroma, that is made up of fats. So once the plaque, the fat, that atheroma ruptures, at that time, the rupturing of the artery can cause the deposition of the platelets, and the thrombus formation can lead to unstable angina. One key factor to be noted here is about ST segment depression. In unstable angina, in the ECG, the ST segment is depressed. Why is it depressed? Because of subendocardial ischemia. What is subendocardial ischemia? There are three layers of the heart. The first layer is epicardium, the second layer is myocardium, and the third layer is subendocardium or endocardium. So subendocardium means that the innermost region of the heart, the innermost layer of the heart, that receives less blood. So there is coronary artery, then there is epicardium, then there is myocardium, and then there is endocardium. So if you see, endocardium is furthest, it is far from the coronary artery. So if your heart will receive less blood due to an occlusion in the coronary artery, the part of the heart which will be affected most is endocardium. Why? Simply because it is very far from the coronary artery. Pericardium will still receive some blood. Myocardium will still receive some blood. But endocardium, since it is furthest from the coronary artery, it will tend to undergo ischemia. So in unstable angina and in stable angina, there is subendocardial ischemia. This means that only the endocardium will suffer from ischemia, right? There's a partial ischemia. Only the endocardium will suffer from ischemia. So that is why in the ECG, the ST segment is depressed. The ST segment is depressed. Shoini, can we take it to the slide of ST segment depression and elevation? Further away. More, this one. So the previous one. So this is the ST segment, right? This is the ST segment. So this is the ST segment elevation and this is depression. Depression comes with stable angina and unstable angina. Why? Because only the endocardium, the innermost layer of the heart, is affected. So when the innermost layer of the heart would be affected, there will be partial ischemia. However, in vasospastic or prinzmetal angina, all the layers would be affected. The damage is transmural. Transmural means epicardium, myocardium, endocardium, all the three layers of the heart would be affected. And that is presented in the ECG as ST segment elevation. So in the other two forms, there is ST segment depression. And in the prinzmetal and vasospastic angina, there is an ST segment elevation. However, this ST segment depression can be transient. It can be transient. It can, once, the situation is resolved, this ST segment depression can be cured. So this is transient. Also, like in the stable angina, the classic angina, this ST segment depression can be there or it cannot be there, because that is exercise induced, that is emotion induced. So once you remove the external stimulus, once you remove that factor which is causing that angina, the situation can be normal. So angina, it comes like an attack. Just like an asthma, it comes like an attack. Angina also comes like an attack. And between those attacks, the person is completely normal. Shoini, we need to go back. Yeah, this slide. So what is classic angina? Classic angina is also known as stable angina. It's very common. It's predictable. Predictable means that you know that when a person is going to exercise, it's going to come. When a person is going to be under a cascade of emotions, it's going to come. So that's why it's known as stable angina. It doesn't come as a surprise. It's quite predictable and it's very common as well. It's triggered by exercise, emotion, or eating. Now, how do we treat it? When a person has a classic angina, or that is also known as exercise-induced angina, we usually advise the patient, the doctors usually advise the patient to place a sublingual GTN. What is sublingual? Anyone? You can type it in the chat box. What is sublingual? Sublingual means that you place the tablet under the tongue. When you place the tablet under the tongue, it is directly absorbed into the bloodstream. It is directly absorbed into the bloodstream and the acute attack of angina is resolved. So GTN is given for the acute attack of the angina, and this is classical angina. What is variant vasospastic angina? As I already told you, that there is a spasm of the coronary artery. Spasm means that the coronary artery is narrowed. There is a spasm of the coronary artery. It's uncommon. It's unpredictable. Unpredictable because you never know when it will come. It occurs during rest or sleep. So how do you treat it? You particularly treat it by focusing on the vasodilation of that narrowed arteries, on vasodilation of the narrowed arteries. You can give calcium channel blockers. You can give long-acting nitrates to manage that variant angina. What is unstable angina? It is also known as acute coronary syndrome. Why is it known as acute coronary syndrome? Acute means sudden. Yes, very good, Vishal. Acute means sudden. So when a thrombi is formed, when a thrombus is formed, so what can happen? That the blood supply to a particular organ can be to the particular heart, to the particular portion of the heart, can suddenly stop or reduce. So that's why it comes under acute coronary syndrome, and that can cause chest pain. So the formation of thrombus is very dangerous because thrombi can also convert into emboli, and when it can convert into emboli, it can get stuck anywhere in the vessel, and that can lead to stroke, that can lead to myocardial infarction, that can lead to DVT, yes, deep venous thrombosis. Lots of things can happen. So that's why it's very dangerous. It's uncommon, it's occasional, and it occurs during rest, right? So this is the basic differences between the classical, variant, and unstable angina. Shoini, we need to change the slide. So this is a flow diagram: vasospasm, fixed stenosis, or coronary thrombosis. So vasospasm means vasospastic angina. Fixed stenosis means plaque, or coronary thrombosis, formation of a thromboid in the which artery? Coronary artery. Who is coronary artery? It's the major conductance vessel. What do you mean by the major conductance vessel? It supplies the left ventricle with the blood. And who is left ventricle? It's the major pumping organ. It's the one which is going to do the systole. It will contract and the blood will go into the aorta, and from aorta it will be pumping to your entire body. So insufficient coronary blood flow. Why insufficient coronary blood flow? Because of all of these three reasons. So what will happen? Decrease oxygen supply to meet the increased myocardial oxygen demand. So your body will be asking for more blood. They will say, I want more blood, right? The body will say, I need more blood to do all the chores, but it wouldn't get more blood. Why it wouldn't get more blood? Because your heart is not receiving enough blood. And when your heart will actually try to meet the demands of the body, what will happen? That a chest pain will occur, because heart doesn't know that there is something wrong in the coronary artery. So that's why it's not getting enough energy. Oxygen demand exceeds the supply. There is an imbalance between the oxygen demand and supply. So it wouldn't be able to supply because it's not getting enough. Myocardial hypoxia. Hypoxia means, what do you mean by hypoxia? Low oxygen supply. So, yes, somebody has raised a hand. Lack of oxygen. Yes, lack of oxygen. So your heart will receive less oxygen. Why it will receive less oxygen? Because already it is receiving less blood. Oxygen is dissolved in the blood. Stimulation of pain receptors within the myocardium. And this is what angina pectoris is. Chest pain, myocardial infarction, blocked artery with hypoxia. So why chest pain is arising? Chest pain is arising because your heart is exerting more to meet the demands of the body. But your heart cannot fulfill the demands of the body because this heart, poor heart, is not also getting enough blood. So there is an imbalance between demand and supply. Shoini, let's go further. So this is again a pathophysiology. Oxygen supply is decreasing and oxygen demand is increasing. Why the supply is decreasing? Now you guys know it. It can decrease due to vasospasm. It can decrease due to atheroma. It can decrease due to thrombi. That is why the demand is increasing. That is why the supply is decreasing. Why the demand will increase? The demand will increase because the heart will pump more. So it's increasing. It's the force of contraction is increased. It is pumping more to meet the demands of the body. So when it is pumping more energy is used, more ATP is used. The heart rate is increased. The heart rate means that the heart is working more per minute, more work per minute. So that will increase the demand because heart is pumping more. It is working more per minute. Increase ventricular wall tension. So this means that the tension inside the ventricular wall will increase because again it will pump more. So more oxygen will be needed to overcome this pressure. So the demand is increasing because the heart is exerting more, in short. Your heart is working more. The workload on the heart is increased and the supply is decreased due to thrombus, vasospasm, or a atheroma. Next slide. So what can be the treatment strategies? How you can overcome? Of course, you can decrease the demand and you can increase the supply, right? How will you increase that supply? The first thing is that you know that the coronary artery is the one which is responsible for supplying the blood to the left ventricle. So you need to restore that coronary blood flow. You need to restore that coronary blood flow. How can you do that? I told you that the reason can be atheroma, the reason can be plaque, or the reason can be vasospasm, vasoconstriction. So you can relieve the vasospasm with calcium channel blockers and nitrates. So we will study the mechanism of each drug one by one in the future slides, but just for the introduction, that vasospasm is there, vasoconstriction is there. So for that, you will treat it with nitrates and you will treat it with a calcium channel blocker. Both of them cause vasodilation. Both of them cause the vasodilation of the veins. Which veins? We will talk about that again. Break the thrombi using thrombolytic agent. So you can break up the thrombi which is formed there in the coronary artery. So for that, you can use thrombolytic agents like streptokinase, urokinase, and prevent the thrombus formation by antiplatelet agents such as aspirin, clopidogrel. You can give different antiplatelet agents to prevent that thrombus formation. Decrease the oxygen demand. Now, how you will decrease the oxygen demand? You need to decrease the workload on the heart. And of course, that you can do it with beta blockers, because beta blockers are very efficient in decreasing the force of contraction of heart and on decreasing the workload on heart. So you can do that with beta blockers. Also, you can decrease the preload with nitrates. What is the preload? That the heart will receive less blood. So if it will receive less blood, right? If it will really receive less blood, then eventually the workload on the heart will be less. And also we can decrease the afterload with calcium channel blockers and potassium channel openers. So afterload is basically, what is afterload? Can someone tell me what is afterload? What is afterload and what is preload? So afterload is that pressure which your left ventricle exerts to pump the blood into the aorta. So basically it is the pressure the heart has to exert while pumping the blood into aorta during that systole. So if we reduce that pressure, if we reduce that afterload, if we reduce that pressure, if we reduce that afterload, what we can do? We can decrease the vascular resistance. And when we can decrease the vascular resistance, this means again causing vasodilation. Vasodilation of the aorta, vasodilation of the arteries which are pumping the blood to the heart. So that will again ease out the process. That can lessen the burden on the heart. Also, we can give potassium channel openers. We will discuss this more in the classification. Once again, please, ma'am. Farhat, what do you want me to repeat once again? Preload and afterload. Don't worry, I will just repeat it in the future slide when we'll be discussing it more in detail while talking about the nitrates, okay? So rest all is clear. If rest all is clear up till now, just give me a thumbs up. Okay, great. So I'll just go through this summary once again. What is this? This is right atrium, this is right ventricle, this is left atrium, this is left ventricle, and the deoxygenated blood comes on the right side of the heart, and after that it goes into the lungs for purification, and after purification it comes back into the left side of the heart through the pulmonary vein, and then left ventricle pumps the blood through the aorta to the entire body, right? One more important thing to remember here is that superior vena cava and inferior vena cava, these are veins. These are very important veins. So when we will talk about nitrates, we will be understanding that nitrates work over here on superior vena cava and inferior vena cava, right? These are veins. Superior vena cava, it collects the blood from your upper part of the body, the dirty blood, the deoxygenated blood, and bring it to the lungs and the right side of the heart. And the inferior vena cava, it brings the blood from the inferior part of the body, from the bottom of the body, and brings it to the right side of the heart. So deoxygenated blood is coming on the right side of the heart, and the left side will always have oxygenated. But oxygenated blood is on the left side of the heart. So deoxygenated blood is on the right side of the heart and oxygenated blood is on the left side of the heart. So who is bringing that deoxygenated blood? Superior vena cava and inferior vena cava. These are very important veins, and keep in mind that nitrates would be working over here. Yes, Zed has a question. Can we unmute him? He has a question. Zed, preferably you can do that at the end of the class, or you can type it in the chat box. Okay, Shoini, let's move on the other slide. Next slide. We have discussed this. So this one. Now this one is classification. Anti-anginal drugs, as we discussed in the start, that what are anti-anginal drugs? Anti-anginal drugs are those which help to relieve the attack of angina. So once you have chest pain, what will happen? You will obviously take anti-anginal drugs. So which is the most important drug? Nitrates. They are the most important drug in the treatment of the angina. Among that, there are two classes, short-acting and long-acting. Short-acting are the ones which are given in acute attack. Right? They are given for the acute attack. So they are available in the form of sublingual tablet. They are available in the form of spray, but they are given in the case of acute attack. So what do doctors direct? That whenever the chest pain starts, keep one of the tablet under your tongue, and then you need to repeat the dose. Like if the pain does not subside with one tablet, you can take another tablet after 5 minutes. And still, if the pain does not subside with another tablet, you can take in another tablet after 5 minutes. So in this way, the maximum dose which can be taken for GTN sublingual is 1800 micrograms. If still the pain doesn't subsides, then obviously you need to rush to the hospital. So these are short-acting ones, glyceryl trinitrate and isosorbide dinitrate. So just if you can see over here that short-acting is always given by the sublingual route. Why? Can you answer it in the chat box that why these tablets, glyceryl trinitrate and also isosorbide dinitrate, the short-acting ones, they are given by the sublingual route? One thing is fast-acting. Another very important thing, to bypass the first pass metabolism. To bypass the first pass metabolism. If we will give it by oral route, it will undergo extensive first pass metabolism, right? So in order to avoid that, because we want that the drug should directly reach to the systemic circulation, it should directly reach into the blood. So to avoid that, we give it by the sublingual route. However, the long-acting drugs can be given orally. Isosorbide dinitrate oral, isosorbide mononitrate, erythritol tetranitrate, penta-erythritol tetranitrate, right? These are the long-acting ones, and they are given for the prophylaxis. They are not given for the acute attack. As you can see that isosorbide dinitrate is coming under both the categories. So there is a difference in the formulation. One is given by the oral route and the other is given by the sublingual route, right? They are the long-acting preparations. They are given for the prophylaxis, so the other attack doesn't come. Second very important category is beta blocker. Propranolol, metoprolol, atenolol, others. So metoprolol, atenolol, these are particularly preferred because they are cardioselective. Cardioselective means there are two type of beta blocker, means that they act on beta receptors in the heart. Beta receptors, they are under the control of sympathetic nervous system. There are two type of beta receptors, beta 1 and beta 2. So beta 1 it is present in the heart. So beta 1 selective, you have one heart and beta 1 receptors are present in the heart. Beta 2, you have two lungs, beta 2 receptors are present in the lungs, also they are present in the blood vessels, but we want beta 1 selective agent. So they can particularly act on the beta 1 receptors in the heart and reduce the force of contraction, reduce the conduction velocity, and reduce the heart rate. So beta blockers, they are very important category. Whenever somebody has an angina attack, we do keep that person on beta blockers after the resolution of the attack, until and unless that beta blockers are not contraindicated. Calcium channel blockers, verapamil. Oh, sorry. Just a second. Shoini, I can't see the presentation. Please, can you share it again?
It's visible.
No, I can't see it. I don't know why.
Is it with everyone?
It's not visible to me.
It's visible. It's visible.
Okay. Okay, so what are, Shoini, are you sharing it again or what?
I'll reshare it for you.
Okay. So calcium channel blockers, I'm just saying it on my own till you share it. Calcium channel blockers, yes. Verapamil, diltiazem, amlodipine, nitroglycerin, and others. So there are two types of calcium channel blockers. One is dihydropyridine type and the other is non-dihydropyridine type. Dihydropyridine type, this category includes amlodipine, nifedipine, and all these drugs. And the non-dihydropyridine type is verapamil and diltiazem. The difference between both of them is that the dihydropyridine type, amlodipine and felodipine and nifedipine, they have a more pronounced action on the blood vessels, whereas the non-dihydropyridine type, they have a more pronounced action on the heart. Then there's a fourth class, potassium channel opener. Nicorandil is the example of this drug. So potassium channel opener means that this is the drug which is used when these options are rather not useful, but it has shown to be equally effective. But potassium channel opening means, so if you go back to action potential, there is depolarization, there is repolarization, and there is hyperpolarization. So when you open the potassium channels for a prolonged period of time, you are inhibiting the contraction. You are keeping the cell in a hyperpolarized state. So hyperpolarized means relaxation of the vascular smooth muscles. Relaxation of the vascular smooth muscles, again, that will lead to vasodilation and it will improve the balance. It will lead to vasodilation and it will ease the blood flow and it will actually improve that balance between the oxygen supply and demand. So basically it is causing hyperpolarization of the vascular smooth muscles. And when there will be hyperpolarization of vascular smooth muscles, this will lead to vasodilation. When there will be vasodilation, the vascular resistance will decrease and the afterload will decrease. Afterload, the pressure the heart has to exert to pump the blood into aorta. So afterload is the pressure. As I told you that from the left ventricle, the blood is pumped into aorta, and from aorta, it goes into your entire body. So afterload is that pressure the left ventricle has to exert to pump that blood into aorta. It's the pressure exerted by the left ventricle during systole. Systole is the contraction. So it will contract, it will relax, it will pump the blood into aorta. From aorta, it will go to the entire body. So that pressure which the left ventricle has to exert, that is afterload. So potassium channel opener will basically decrease the afterload. When it will decrease the afterload, what will happen? That more blood, the blood will flow more easily to the body. Other anti-anginal drugs, ranolazine, ivabradine, dipyridamole. So for your exam purpose, like for the OPRA exam, usually dipyridamole is being asked, and not even that, like That is also not very important. But diparacetamol also, it's basically causing coronary vasodilation. It's a PDE5 inhibitor. It's a phosphodiesterase inhibitor. Now again, what is phosphodiesterase is, I will just discuss that while discussing nitrates, but it is a phosphodiesterase inhibitor. And by inhibiting that enzyme, it causes coronary vasodilation. Guys, you can ask the questions in the end. As said by Shoini, you can ask the questions in the end and she'll open the mics then. I can see the raised hands though. So Shoini, next slide. So coming to nitrates, the very, very important drug in angina. What are nitrates doing? This is something very important. They are reducing the preload by causing venous dilation. To some extent, they also dilate the arteries and they reduce the afterload on the heart. So basically, now let's say that the patient is having angina, right? If the patient is having angina, we will give nitrates to that patient. We will give nitrates to treat the attack of angina. So what will nitrates do? They will cause dilation. They will cause venodilation. Venodilation means that they will dilate the veins. Which veins, to be more specific? Superior vena cava and inferior vena cava. Because superior vena cava and inferior vena cava, they bring the blood from the body to the right side of the heart. So when they will be dilated, what will happen? That all the blood will remain in the superior vena cava and inferior vena cava because their capacity is increased. Although already the veins have increased capacity, but by causing their dilation, we will increase their capacity. So all the blood will remain in superior vena cava and inferior vena cava, and less blood will go to the right side of the heart. When less blood will go to the right side of the heart, eventually less blood will go to lungs, less blood will go to the left side of the heart, and the cardiac workload will decrease. The cardiac workload will decrease, the oxygen consumption will decrease, and the heart will do less pumping. So you are decreasing the workload on heart. You are decreasing the workload on the heart. Why? Because there is an occlusion in the coronary artery. So you want to decrease the workload on the heart. For that, you will dilate the veins, which are sending the blood to the heart. So what is preload? It is the amount of blood which is coming into the right side of the heart. Who is bringing the blood to the right side of the heart? Superior vena cava and inferior vena cava. Now, how are you going to decrease that amount of blood which is coming into right side? By causing venodilation. Venodilation, who are the veins? Superior vena cava, inferior vena cava. You're going to dilate them by giving nitrates. More of the blood will remain in the veins. Less of the blood will go to the heart. So in this way, you are reducing the preload on the heart. At high doses, they can also dilate the arteries and reduce the afterload on the heart. So on high doses, they can also cause vasodilation of the aorta. They can also cause vasodilation of the aorta. So when they will cause vasodilation of the aorta, what will happen? More blood will stay in the aorta and you will decrease the demand and supply. Just a second. But if the heart is pumping less blood to the body, wouldn't the body be hypoxic? No, the body wouldn't be hypoxic. Why? Because you need to create a balance between the demand and supply. So if you will actually, the demand will be less. Let's say when the demand is less, the person tries to adjust in that little demand, right? And in that little, so we are basically our goal is to keep a balance between that supply and demand. So heart will demand, if you will supply less, ultimately the demand will also be less, right? If you will supply more, the demand will be more. So in this case, there is an occlusion. There is an occlusion. You need to resolve that chest pain. You need to decrease that workload on heart, because if you will not decrease the workload on heart, what will happen? The heart will keep on pumping. So you need to keep the heart out of that exertion state. So for that, the primary goal would be to decrease the preload on the heart, to decrease the workload on the heart. When you will decrease the workload on the heart, whatever the blood would be there, Whatever the blood would be there, that will go and that will, that will meet the demands of the body. So you're keeping a balance between the demand and supply. That is the major goal in angina. Right? So there is one thing, one very important thing, that you are dilating the veins and you are decreasing the preload. So when your heart will receive less blood, it will pump less blood, right? When your heart will receive less blood, it will pump less blood. So you're easing out the process. You're decreasing the workload on the heart in order to avoid that chest pain, which can come because of increased pumping of heart. Shoini, please take it to next slide. We'll come back again on this one. So this is again a very, very important slide. It talks about the mechanism of action of nitrates and nitrites on smooth muscle. So let's talk about it again. That once the person has an angina, he has taken in the GTN. He has an acute attack of angina. He has taken a glyceryl trinitrate tablet. Now what will happen? That will be absorbed in the bloodstream. That will go in the bloodstream and that will be absorbed. Now this glyceryl trinitrate has to release free nitric oxide, NO, free nitric oxide. How it will be releasing that? It will be denitrated. It will be denitrated enzymatically and then it will release nitric oxide. So you took GTN, GTN is converted, it is denitrated, and after denitrated, it releases the free nitric oxide. Now this nitric oxide in the blood vessel will activate an enzyme. Who is that enzyme? Can anyone tell me? The nitric oxide will activate one enzyme. Who is that enzyme? It's guanylyl cyclase. Guanylyl cyclase. Once guanylyl cyclase will be activated, what will happen? GTP will be converted into cyclic GMP. GTP will be converted into cyclic GMP. And then this cyclic GMP will do two things. We will talk about that this is the main mechanism of action of nitrates. You took nitrate is denitrated into nitrate, GTN is denitrated, it releases nitric oxide. Nitric oxide will go in the blood vessel and it will activate guanylyl cyclase that will convert GTP into cyclic GMP, and this cyclic GMP will do two things. The first thing it will do is that it will block the calcium channels. It will block the calcium channels. So as you can see that nitrodilators are doing two things. The first thing it will do that it will block the calcium channels. So when it will block the calcium channels, what will happen? Less calcium will come in the blood vessel. When less calcium will come in the blood vessel, there will be no contraction. So no contraction means that the blood vessel will remain dilated. It will be relaxed, because we know that calcium ions are very necessary for contraction, right? So we will block those. This nitrodilator will block the calcium channels. Blocking calcium channel means no calcium in the blood vessel. When there is no calcium in the blood vessel, this means that relaxation would be there. The second thing what it will do is that this nitrodilator, or you can say this nitric oxide, actually is required. This nitric oxide, this increased GMP. This increased GMP causes the phosphorylation of the myosin light chain kinase, right? There is an enzyme called myosin light chain kinase. This is basically activated. When this activates normally, in a normal person, when this is activated, it becomes phosphorylated. So it converts the myosin into its active form, and then that active myosin interacts with the actin and contraction take place. You know that for the contraction of a muscle, there should be an interaction between actin and myosin filaments. When they interact, muscle contraction takes place. But before that, there is a complete procedure that the myosin light chain kinase is activated and converted into its phosphorylated form. Then that phosphorylated myosin light chain kinase converts myosin into phosphorylated myosin, which is again the active form of myosin. And then that active form of myosin combines with actin and contraction takes place. But nitrates, nitric oxide, will inhibit this all step. When it will inhibit all these steps, what will happen? There will be no contraction. When there will be no contraction, there will be dilation. relaxation, dilation, right? So basically this nitric oxide is working on two spots. One, it will directly inhibit the entry of calcium ions by closing the gate, and it will inhibit the contraction and cause the relaxation of the blood vessel. Secondly, it will by this increasing CGMP. This CGMP will inhibit myosin light chain kinase, inhibit the phosphorylation of the myosin light chain kinase. Ultimately, active myosin will not be formed. When active form of myosin will not be formed, it will not react with actin, and actin myosin interaction will not take place, and contraction will not take place, which will lead to vasodilation, relaxation of the blood vessel. Is it clear, guys? Give me a thumbs up if it's clear. Now my question is that which kind of blood vessel it is dilating? Is it dilating a vein or is it dilating an artery? Is it dilating a vein or is it dilating an artery? It is causing vasodilation. We said that it is causing the vasodilation of the blood vessel. But is it dilating a vein or is it dilating an artery? Yes, it's dilating a vein. It's a vasodilator. And why? Because that enzyme which denitrates GTN and releases nitric oxide, which denitrates GTN and releases nitric oxide, that is more in veins. Your arteries do not have that enzyme. So this GTN, once it goes into your body, it will go to the arteries, it will go to the veins, it will go to both of them. But the enzyme which is required for denitrating it and releasing that active nitric oxide, that is more in veins and that is less in arteries. At high doses, it will also affect the arteries. It will decrease the afterload, but it is primarily a vasodilator. Nitrates are primarily a vasodilator. They decrease the preload. They decrease the amount of blood which is coming into the heart. And why they are acting on veins? Because that enzyme which is required for conversion of nitrates into nitric oxide, that is present in veins. So if you get that question that why they are acting primarily on the veins, so you should know, because the enzyme which is responsible for its for the release of free nitric oxide, that is present more in veins. So this is the mechanism of action, which has its own significance, important. And I wouldn't say that you should remember all these names while giving OPRA, 𝗙𝗏 and all that stuff. But yes, you should know that it is primarily a vasodilator. You should know that it decreases the preload. And you should know that there is an enzyme which is present in the veins, which releases the free nitric oxide. Shoini, let's go back to the previous slide. Right, so now you know the mechanism of action. It's a vasodilator, but at high doses, it can also reduce the afterload on the heart. Side effects, very, very important with respect to nitrates. They have frequently come in exam that it causes vasodilation. Since it's causing vasodilation, so one of a very important side effect is that it will cause throbbing headache. Why? Because it can cause vasodilation in arteries. Yes, it can cause vasodilation in arteries. That is why it will decrease the afterload, but to not that extent and not at typical doses, at high doses. Right? So at high doses. So the most important side effect is throbbing headache. Why throbbing headache? Because it causes the vasodilation of the blood vessels. So it can also dilate the blood vessels in the brain and it can cause throbbing headache. Flushing, weakness, sweating, palpitation. All these side effects are due to reflex tachycardia. Why reflex tachycardia? Because since it is causing vasodilation, so vasodilation of the blood vessels mean that will it increase the BP or will it decrease the BP? Will it increase the BP or will it decrease the BP? All of you can type in the chat box. Increase. Why? It's causing vasodilation of the blood vessels. It is decreasing the peripheral resistance. Yes, it will decrease the BP. So when the BP is decreased, under the influence of sympathetic nervous system, our body activates our parasympathetic nervous system, because both of them go hand in hand. So when there is too much decrease in the blood pressure, your body will activate parasympathetic nervous system, and then that parasympathetic nervous system will send a signal to the heart, and that will increase your heart rate. That will increase your heart rate. So basically, you can just remember that because of decrease in the blood pressure, there will be a reflex tachycardia. There will be a reflex tachycardia, not the parasympathetic nervous system. Sorry, that was my bad. Parasympathetic nervous system is responsible for causing bradycardia, not tachycardia. So because of a too much decrease in the BP, there can be reflex tachycardia. There can be reflex increase in the heart rate, right? There can be reflex increase in the heart rate. So because of that reflex tachycardia, sweating can be there, palpitation can be there, flushing can be there, dizziness can be there, fainting can be there. So all these symptoms and side effects can be there. But just keep in mind that all these symptoms and all these side effects are happening because of vasodilation. Because of vasodilation of arteries in the brain, there can be throbbing headache. Because of the vasodilation, there can be hypotension. Because of hypotension, the person's blood pressure will decrease to such an extent that there can be reflex tachycardia, there can be sweating, there can be flushing, dizziness, palpitation. Interaction. So there is a very important interaction between nitrates and phosphodiesterase 5 inhibitors. What is phosphodiesterase? Can somebody tell me? Sorry, I drink water in between. I can't stay without that. So what is phosphodiesterase? Phosphodiesterase is an enzyme which breaks down cyclic GMP, It is responsible for the destruction of the cyclic GMP in the body, right? So there are certain drugs such as sildenafil. There is a very important interaction between nitrate and sildenafil, and it usually comes in exam. Sildenafil is a drug which is given for erectile dysfunction. It is given for erectile dysfunction. It is also given for pulmonary arterial hypertension, but it is primarily given for erectile dysfunction. So how does this drug works? Sildenafil, it inhibits the enzyme phosphodiesterase 5. So phosphodiesterase destroys cGMP, but sildenafil is a phosphodiesterase inhibitor. So this means it will inhibit the destruction of cyclic GMP. So when its destruction will be inhibited, the levels of cyclic GMP will increase in body. Now keep in mind, nitrates also increase the levels of cyclic GMP in the body, and this drug will also increase the levels of cyclic GMP in the body. Then what can happen? This cyclic GMP is responsible for vasodilation. So this means there will be too much of cyclic GMP in the body, too much of vasodilation. So profound hypotension, profound decrease in blood pressure, profound vasodilation, profound hypotension can take place. So these two drugs together have an additive effect. So it is very important for a doctor to see when the patient comes to him. So if you are prescribing him nitrates, you should make sure that he is not taking any kind of phosphodiesterase 5 inhibitor, because there will be additive effect, because both of them are increasing the levels of cGMP in the body. So let's say that there is a patient who is suffering from unstable angina, right? And he also has erectile dysfunction. Now he is taking sildenafil for his erectile dysfunction, and the doctors give him nitrates, a long-acting nitrate for his angina. So what will happen? That if he will take both of the tablets together, there will be too much of cyclic GMP in the body. When there will be too much of cyclic GMP in the body, there will be too much of vasodilation. So the person can go in shock. The person can go in excessive hypotension, or even myocardial infarction can take place because of that reflex tachycardia. So what you need to make sure is that the person, if he is on nitrate, he is not taking any other phosphodiesterase inhibitor, because for the destruction of cyclic GMP, you need phosphodiesterase. And if you will inhibit that phosphodiesterase, ultimately, you will inhibit the destruction of cGMP. And reducing its destruction means you are increasing its level in the body. So this is one of a very important interaction which comes in exam, that nitrate can potentiate the hypotensive effect of PDE5 inhibitors. Combination may result in profound hypotension or myocardial infarction and are contraindicated. Not only sildenafil, any other phosphodiesterase inhibitor as well, such as nicorandil. Nicorandil also has an effect on phosphodiesterase, such as dipyridamole. It has also effect on phosphodiesterase inhibitor. So whenever you are taking nitrates, make sure that the patient is not taking any other phosphodiesterase inhibitor. For patients with hypertension and angina, verapamil is the drug of choice. So we will discuss this chart in the end, where we will study comorbidities with angina. Shoini, you can move it to the next slide. This is done. So dosages, this is very important. Glyceryl trinitrate is stored in an amber glass color container. Why amber glass color container? Because it is light sensitive. So you're not supposed to store it in a plastic container. You should store it in amber colored container. Administer it sublingually, already discussed, to avoid the first pass effect. Once the container is open, consume the tablets within 8 weeks. Okay, do not keep it for long. The normal dose for GTN is 0.5 to 1 mg sublingual. Duration of action is 10 to 30 minutes. So this is a general dosage range. They might not give you this exact dosage in the paper. They can give you something in between, like 300 to 600 microgram, 400 to 800 microgram. So you should know the general range. Sublingual spray and sublingual tablet. As I've already discussed, that you can give it in the form of sublingual tablet. 3 to 600 microgram, repeated every 3 to 4 minutes until the pain subsides, to a maximum of 1800 microgram tablet. So let's just assume you took 1.5 mg tablet, then you can take in another 0.5 mg tablet, and then you can take in another 0.5 mg or 0.25 mg tablet. If the pain still doesn't subside, then you need to rush to the hospital, because you can't take more than 1800 micrograms. Similar case is with the spray. It is also available in the form of spray. You can take 1 to 2 sprays. Repeat after 5 minutes if required, if to a maximum of 3 sprays. If the pain doesn't subside, rush to the hospital. Sublingual tablets have been discontinued. However, an alternative may be available via Section 19A approval according to AMH. So AMH is Australian Medicine Handbook, right? These are the available preparations right now at the moment in Australia. Section 19A means that in some circumstances, due to some shortage, maybe due to a shortage of the tablet, maybe due to some sort of manufacturing problems or batch failure, temporarily the drug is not available in the country. Like it's not available the sublingual tablets are not available in Australia currently. So you need a Section 19A approval. What is this Section 19A? It's a temporary approval to import or supply a drug, right? When there is a shortage in the country. And of course, that is in the interest of the public. So if somebody needs this tablet, you can import it through Section 19A approval according to AMH, because currently the sublingual tablets are not available in Australia. So, but you can get it through this approval. Show any next slide. Isosorbine mononitrate, it's the long-acting drug. So as far as the OPRA is concerned, this is the only thing you need to know about isosorbine mononitrate, that it is orally available agent. It doesn't undergo first-pass metabolism, and it's the long-acting preparation, right? Dosing schedule, the last dose is in afternoon. The sustained release tablets are also available, and the dose can be given once daily in the morning. So obviously the sustained release tablets make a tablet more user friendly. You can just take 1 tablet in the day, and the tablet is the dose is released in your body throughout the day. So it's a very convenient mode of dosage form. Cyanide poisoning. This is a very important use of nitrates, and it has been asked a couple of times in the KAPS exam, in the OPRA exam. What is the reason behind that? That nitrates can be given in cyanide poisoning. So cyanide is obviously a poison, right? If somebody takes it accidentally, you need to get this cyanide out of your body. How will you do that? You can give nitrates. What can nitrate do? Nitrate generate methemoglobin. So you have hemoglobin in your body, right? Hemoglobin has iron, and that iron combines oxygen. But methemoglobin is that form of hemoglobin that cannot bind to oxygen, right? It does not have iron in the ferrous form, rather it has it in the ferric form. So it can't bind oxygen. So nitrates generate methemoglobin, right? And then nitrates have a very high affinity for cyanide radicals. They generate, methemoglobin, and methemoglobin has a very high affinity for cyanide. And what is the product form? Cyan methemoglobin is formed. Now, this cyan methemoglobin, what is the use of cyan methemoglobin? Then after giving a nitrate, such as sodium nitrite or amyl nitrite, you can give sodium thiosulfate. What does sodium thiosulfate do? It sets the methemoglobin free and it forms sodium thiocyanate. And this sodium thiocyanate is then excreted in the urine. I will repeat it again. Nitrate, such as sodium nitrite or amyl nitrate, it generates methemoglobin, right? Methemoglobin combines with the cyanide radicals, it forms cyan methemoglobin. Then this cyan methemoglobin, after giving amyl nitrite or sodium nitrite, you give sodium thiosulfate. The administration of sodium thiosulfate follows it. So you will give sodium thiosulfate. What will the sodium thiosulfate do? It will form sodium thiocyanate, and methemoglobin will be free again. Sodium thiocyanate is comparatively less toxic. It is excreted into urine, and that is how you get the body rid of cyanide. So nitrates are used in cyanide poisoning, particularly sodium nitrite and then amyl nitrite. Show any next slide. Beta blockers. Beta blockers is a very important class in the treatment of angina. After nitrates, nitrates is a compulsory one. You need to give it for the termination of the acute attack. Also, you need to give long-acting nitrates for the prophylaxis, right? But beta blockers, they are given in the prophylaxis. Now, beta blockers like these nitrates or like calcium channel blockers, they do not directly dilate the coronary arteries, right? They do not directly dilate the coronary arteries. Instead, they act on the heart. Why on the heart? Because your heart has beta-1 receptor. So they are going to bind to the beta-1 receptor on the heart. They are going to decrease the force of contraction. They are going to decrease the heart rate. They are going to decrease the wall tension. So basically, they decrease the oxygen demand. They decrease the oxygen demand. So by decreasing the oxygen demand, they also allow a better redistribution of the blood, right? Because let's say when there was a higher demand, so there, as I told you earlier, there are 3 layers of heart: epicardium, myocardium, and endocardium, right? So when there is an increased demand, what will happen? All the blood will go to epicardium, and endocardium will receive less blood, right? But when the demand is decreased, what will happen? That pericardium will not be having that much demand, right? So the blood can go to more inner areas. It will go to endocardium. So the subendocardial ischemia will not happen. It will prevent that subendocardial ischemia. I told you that endocardium is furthest away from the coronary artery. There is coronary artery, there are resistance vessels, there is epicardium, myocardium, and endocardium. So endocardium is very far from the coronary artery. That's why this is the layer which undergoes ischemia the most. We need to prevent that ischemia. So that's why beta blockers, they will distribute the blood flow in such a way that the blood flow to the endocardium will be preserved. So they do not dilate the coronary arteries or other blood vessels. They reduce the oxygen demand, and the subendocardium flow is preserved due to favorable distribution, right? So they decrease the heart rate, they decrease the force of contraction, and they actually distribute the blood in a better way. So they are basically decreasing the myocardial oxygen demand. They're basically decreasing the myocardial oxygen demand. They will decrease the contractility of the heart. They will decrease the heart rate. They will give a better flow to endocardium. And they are very beneficial in exercise or stress-induced angina, right? So anybody who is suffering from stable angina, classical angina, it is one of the first drugs which is given prophylactically, right? Nitrates is compulsory, but beta blockers is first drug until and unless it is contraindicated, such as in patients with asthma or in patients with vasospastic angina. Why they are contraindicated, I will discuss that in the end. Therapeutic benefits: all beta blockers effectively reduce the frequency and severity in angina. They increase the exercise tolerance. Long-term use can reduce the risk of sudden cardiac death and ischemic heart disease, right? Because what will happen that it will preserve the subendocardial blood flow. It will maintain a proper blood flow to the endocardium. So the chances of ischemic heart disease, the risk of death associated with ischemia becomes less. Preferred drugs, obviously the cardioselective agents which only act on beta-1 receptor in the heart, they are preferred mode, such as atenolol, metoprolol, bisoprolol, they are preferred mode. Non-selective beta blockers, example propanolol, can worsen variant angina due to unopposed alpha-mediated vasoconstriction. Can somebody explain this line in the chat box, that what is happening? Why should non-selective beta blockers should not be given in a vasospastic angina? So one thing is that in your blood vessels, now this is again a very separate topic which is discussed primarily in autonomic nervous system, but I will give a bit of introduction about it, that your sympathetic nervous system has two kind of receptors, alpha receptors and beta receptors. Among alpha, there is alpha 1, alpha 2, beta 1, beta 2, beta 3. So in your blood vessels, there are two types of receptors. There is alpha 1 and there is beta 2. Alpha 1 is responsible for vasoconstriction and beta 2 is responsible for vasodilation. So in normal circumstances, the blood vessel diameter is maintained by these two receptors, alpha 1 and beta 2. Alpha 1 will cause constriction, beta 1 will cause dilation. The size of the blood vessel will be maintained. Constriction, dilation, constriction, dilation. But what happens in vasospastic angina? In vasospastic angina, the coronary artery is already narrowed. There is vasospasm, there is spasm. The coronary artery is already narrowed. Now, in that same artery, you have alpha 1 and you have beta 2. Now, imagine an artery which is already narrow. It has alpha 1 receptor which will cause vasoconstriction and there is beta 2 receptor which will cause vasodilation. Now, if you will give a non-selective beta blocker such as propanolol, which will act on beta 2 receptor as well as beta 1 receptor. By blocking the beta 1 receptor, it will decrease the heart rate, it will decrease the force of contraction. But by blocking the beta 2 receptor, it will block that vasodilation. It will block that vasodilation. But it is not acting on alpha receptor. So alpha 1 mediated vasoconstriction will be there. Beta 2 mediated vasodilation will be blocked, but alpha 1 mediated vasoconstriction will be there. So it can further worsen the condition of the patient of a vasospastic angina, because the artery can undergo further vasospasm. It can further undergo vasoconstriction. Why? Because beta 2 mediated vasodilation is blocked by non-selective beta blocker. It's propanolol. It's non-selective in its action. It will block both beta 1 and beta 2 receptor. It does not affect alpha receptor. It will block both beta 1 and beta 2 receptor. So by blocking beta 2 mediated vasodilation, it will worsen the condition of a person with vasospastic angina. Already there is vasospasm, the coronary artery is narrowed. Now further, you will block the beta 2 receptor, which is causing vasodilation. But alpha 1 mediated vasoconstriction is still there because you're not blocking alpha 1 receptors. So what will happen? The condition of the person will worsen. So beta blockers should not be given in vasospastic angina, particularly the non-selective ones. You can give beta 1 selective, but it is also good to avoid beta 1 selective. And according to AMH, in vasospastic angina, you rather prefer calcium channel blockers and long-acting nitrates. So you are not supposed to give beta blockers in vasospastic angina. You can give them in unstable angina, you can give them in stable angina, but do not give them in vasospastic angina. Is it clear? If it's clear, give me a thumbs up. Okay, Shwini, then let's switch to the next slide. So beta blocker, it will block the beta 1 receptor of the heart rate will decrease, force of contraction will decrease, cardiac workload will decrease, myocardial oxygen demand will decrease, supply will increase. Why supply will increase? Because it will increase the blood flow to the myocardium, endocardium, the innermost layer. Show you next slide. Calcium channel blockers, there are of two types, dihydropyridine, non-dihydropyridine, verapamil, diltiazem are the non-dihydropyridine, nifedipine, amlodipine, they are the dihydropyridine type. Now, Shoini, let's move to the next slide to understand the mechanism of action first. So what will calcium channel blockers do? You must have already an idea that calcium channel blockers block the entry of calcium ions, right? So normally what is happening that through calcium channels, calcium comes inside the blood vessel, and once it is inside the blood vessel, it binds with calmodulin. Who is calmodulin? Calmodulin is a calcium binding protein. It has a capacity to bind 4 calcium ions altogether, like at a moment. So it binds the calcium ions, calcium calmodulin complex is formed. Once calcium calmodulin complex is formed, what happens? The same thing. Myosin light chain kinase is converted into its active form, which is the phosphorylated myosin light chain kinase. Then that phosphorylated light chain kinase converts inactive myosin to active myosin. Like it converts the myosin into its active form, which is the phosphorylated myosin. And then that phosphorylated myosin interacts with actin, and once actin myosin filament interact, contraction of the muscle take place. This is the basic phenomena. What is happening, how action potential is being generated, how contraction is happening, right? So what this calcium channel blocker will do, it will block the calcium channel in the smooth muscles. So once the calcium channels will be blocked, calcium wouldn't come inside. When calcium wouldn't come inside, calcium calmodulin complex wouldn't be formed. When this complex wouldn't be formed, what will happen? Inactive will remain inactive. Dephosphorylation wouldn't take place. When dephosphorylation wouldn't be taking place of myosin light chain kinase, myosin wouldn't be converted to its active form. When myosin wouldn't be converted into its active form, it wouldn't interact with actin. When actin and myosin wouldn't interact, contraction wouldn't take place. What will happen? Relaxation. Relaxation means vasodilation. So dilation of vascular smooth muscle. This is one way. Shoini, let's move back to the previous slide. This is one way, right? Smooth muscle relaxation. But calcium channels are not only present in the smooth muscles, they're also present in the heart. So it also basically inhibits the entry of calcium ions into the myocardial cells. How? By inhibiting the L-type calcium channels. So L stands for long-lasting channels. They open slowly, but they open for a longer period of time. So calcium channel blocker delay the recovery of L-type calcium channels from an inactive state to an active state, right? From an inactive state to a resting state, which reduces the pacemaker activity and conduction. So basically there are 3 stages of channel. L-type calcium channel, or even any type of T-type calcium channel. There are 3 stages of a channel. What is that? Inactive state, resting state, and active state, which is the open state. So wherever, just imagine a door, right? A door is open. So what happens when the door is open? When the door is open, calcium channel will come, calcium ions will come in. So if a channel is in an open state, what will happen? That calcium ions will come in and contraction will take place. Soon after the open state, there is an inactive state. What is the inactive state? Inactive state, imagine a door which is jammed, So when a door is jammed, it's open, but the ions cannot come in. Why? Because the door is jammed, so the ions can't come in. In the resting phase, the door is closed, but it can open anytime soon. So normally, this transition from open to inactive to closed state is very fast. It is happening within milliseconds. But what do calcium channel blocker do? They keep your channel, L-type channel, in the inactive state. Now, what is that inactive state? The jam state. They will keep it in a jam state. So now the ions cannot come inside. So if it will go back to the resting state quickly, what will happen? It will go back to the open state quickly, because in the resting state, the door is closed. It is properly closed, but somebody can open it, right? Somebody can open it quickly. So we do not want it to go in the resting state. So what does these calcium channel blockers do? They delay the recovery of an L-type calcium channel from an inactive state to the resting state. Ultimately, when it will not go into the resting state, it will not go to the open state. And when it will not go to the open state, the calcium ions will not come inside. So it keeps the channel in the inactive state. It keeps the channel in the jammed state. So the ions cannot come inside, right? So this is how they are working. So in the smooth muscles, they are working through that phenomena of they're inhibiting the actin myosin interaction, and in the heart they are delaying the recovery of calcium channels, L-type calcium channels. They are keeping it in the inactive state. So they are this results in a negative chronotropic, inotropic, and dromotropic effect, meaning a reduction in the heart rate. Chronotropic means reduction in the heart rate. Inotropic means decrease in contractility, and dromotropic means decrease in conduction velocity. So when it decreases the conduction velocity, this is the reason that calcium channel blockers can also be given in arrhythmias. Okay. Adverse effects. There are multiple adverse effects of calcium channel blocker, but for your exam point of view, one which is very important, that they cause pedal edema, they cause peripheral edema. All the dihydropyridine types and non-dihydropyridine types, like all of them, they cause pedal edema. However, it is more prominent with dihydropyridine type like amlodipine and nifedipine. And with the non-dihydropyridine types like verapamil and diltiazem, constipation is very common. They can also cause ankle edema, pedal edema, peripheral edema, but constipation comes more common with them. And ankle edema, pedal edema, that's very, very common with calcium channel blockers. Nifedipine, which is a dihydropyridine type, that can cause glucose intolerance. It can decrease the insulin release. So this means it can raise the blood sugar levels and it can decrease the insulin release. Shoni, let's move to the next slide. This is done. Okay, now this is the last slide, treatment of angina in patients with concomitant disease. Concomitant disease means that they have some other disease as well, right? So always, before starting the treatment, evaluate the condition of the patient. That is a protocol according to AMH, right? Manage the risk factors. What are the risk factors? That if the person is smoking, ask him to quit smoking. If the person is diabetic, we should make sure that his diabetes is in control. If the person is having dyslipidemias, so we make sure that his cholesterol levels are controlled, either through the dietary pattern or either he's taking a statin. So why do we do that? To prevent the progression of the disease, to prevent the further attack, to prevent the further progression of the disease to myocardial infarction, right? So this is very important. Second thing which I would like to add is that beta blockers are one of the first line treatment along with the nitrates. They are the recommended initial therapy. Nitrates like GTN and dinitrate, they are given for the termination of the attack sublingually, and long-acting nitrates, they are given for the prophylaxis along with beta blockers. This is the first line prophylaxis, right? Calcium channel blockers like verapamil and diltiazem, they are usually recommended when you can't give beta blockers. They are contraindicated. Now, where are they contraindicated? One condition I have already told you. They are contraindicated in, write it in the chat box. I'm not going to mention it. You need to write it in the chat box. They are contraindicated in. And the second condition is that they should not be given in asthma. Why they should not be given in asthma? Because beta blockers can block the beta-2 receptor in the lungs. So you have two lungs and beta-2 receptor are present in the lungs. So they can block the beta-2 receptor in the lung and they can cause bronchoconstriction. They can prevent that bronchodilation, because when normally when epinephrine, norepinephrine, or the beta agonist drugs, they bind to the beta-2 receptors in the heart, they cause bronchodilation. So beta blockers, they can cause bronchoconstriction, and that can affect asthmatic patients, right? I haven't gotten any answer in the chat box that when are beta blockers contraindicated. One situation is that they are contraindicated in asthmatic patients. Yes, Vishal, good. They are contraindicated in prinzmetal angina, vasospastic angina, variant angina, right? Whenever a name of a disease is given by 2 to 3 names, make sure you remember all the names, because they can ask you interchangeably. So beta blockers are contraindicated in vasospastic angina, particularly the non-selective ones, but it's better to avoid the beta-1 selective agents as well. Right? So in vasospastic angina, do not give beta blockers. In asthmatic situation, do not give beta blockers. So in that condition, you can consider the alternatives. Avoid beta blockers in diabetics. Why do you need to avoid them in diabetics? Because diabetic patients are usually on drugs which lower the sugar levels, and they can often go in hypoglycemia. So if you are giving, and what is the prime key symptom of hypoglycemia? Increased heart rate. When a person is suffering from hypoglycemia, the person is having increased heart rate. He can go under flushing, he can go under hypotension, and beta blocker can mask all these symptoms. They can mask all these symptoms because beta blocker can mask the symptom of tachycardia, because beta blocker will decrease the heart rate. So if somebody is on a beta blocker and somebody is a diabetic, now let's say for his diabetes, he is taking insulin, right? Now you guys know that how much hypoglycemia is common with insulin, right? He is taking insulin, suddenly his blood levels have fallen to such an extent that he's suffering from hypoglycemia. But if he is on beta blocker as well, what will happen? The prime symptom of hypoglycemia is that the heart rate is increased. But what will beta blockers do? Beta blockers, by blocking beta 1 receptors on the heart, they will decrease the force of contraction. They will decrease the heart rate. So the symptom of hypoglycemia wouldn't come out. So the person can go in shock. This is a literally emergency condition because the symptoms will be masked. So it's good. So it's better not to give beta blockers to diabetic patient. Okay, now let's read what's written. Concomitant disease, drug used in treating angina. If there is no concomitant disease, none. Long-acting nitrate, beta blocker, calcium channel blocker. Recent myocardial infarction, long-acting nitrate, beta blockers, right? If you had a recent infarct, so it's good to give a myocardial infarction because that will actually prevent the ventricular remodeling, that will decrease the heart rate, that will decrease the force of contraction. So that will improve the survival in a myocardial infarction patient. In asthma and COPD, do not give beta blockers, but rather give long-acting nitrates and calcium channel blockers. Hypertension. In hypertension, you can give beta blockers, you can give calcium channel blockers, you can give long-acting nitrates. Any of the drug can be given, right? Beta blockers can be given. If the beta blockers are not giving sufficient effect, you can add a calcium channel blocker. But make sure that beta blockers and calcium channel blockers such as verapamil and diltiazem, the non-dihydropyridine type, they can never be given together. Why? Because excessive bradycardia can happen. Calcium channel blockers also decrease the heart rate and beta blockers also decrease the heart rate. So calcium channel blockers, particularly the non-dihydropyridine type, verapamil and diltiazem. Why? Because they have more pronounced action on the heart. Whereas the dihydropyridine type, amlodipine, nifedipine, they have more action on the blood vessels. They can still be given with beta blockers. But verapamil and diltiazem and beta blockers, they should never be given together because of severe risk of bradycardia. And this is one of the exam questions as well, that, and it is clearly mentioned in AMH, that calcium channel blockers should, such as verapamil and diltiazem, should never be combined with beta blockers because of additive bradycardia, right? So in hypertension, any of the drug category can be given. In diabetes, long-acting nitrate and calcium channel blockers can be given. Why? Because I told you that beta blockers can mask the symptoms of hypoglycemia. In chronic renal disease, long-acting nitrates can be given, beta blockers can be given, calcium channel blockers can be given, right? Beta blockers, again, will they decrease the heart rate and they will decrease the force of contraction. Calcium channel blockers can also be given or added, particularly if the hypertension is one of the issues in chronic renal disease and that is not being managed. You can give the vessel selective, the non-dihydropyridine types, the dihydropyridine types, amlodipine, felodipine, nifedipine, along with beta blockers. Right? So in chronic renal disease, all of the categories can be given. Just make sure you are not supposed to give beta blockers in asthma or COPD. You are not meant to give beta blockers in diabetes. You are not meant to give beta blockers in vasospastic angina. These are three important conditions where you are not meant to give beta blockers. Okay, guys, so test your knowledge. This is your quiz. You can give the answers in the chat box. Why CCB can't be given in recent MI? CCB can be given in recent MI. There is no there is no such thing that it cannot be given. It can be given. But when you're talking about angina, right, at that time, beta blocker is more preferred. So when you talk about how do you get questions in OPRA, guys, you get it like which is the first line, which is more preferred. It is not the case that you can't give CCBs in MI. CCBs can be given in MI, but what is the more preferred agent prophylactically once somebody has an angina? That is beta blockers. Okay, so the first question, you guys can answer in the chat box. The nitrate which does not undergo first pass metabolism is isosorbide mononitrate, nitroglycerine, isosorbide dinitrate, or propanol. So now you need to figure out that 3 of them are nitrates, while the 4th one is beta blocker. The nitrate, it's isosorbide mononitrate, right? Because isosorbide dinitrate, it comes in 2 forms. I told you one was sublingual preparation and one was the long-acting preparation. So the sublingual preparation can go into first-pass metabolism. So your answer is A, isosorbide mononitrate, which is the long-acting preparation, and it does not go under first-pass metabolism, and it can be given orally. Glyceryl trinitrate is given by the sublingual route because of A, B, C, and D. What are your answers? Glyceryl trinitrate is given by the sublingual route because of short T-half in plasma, hepatic first-pass metabolism, lower bioavailability by the oral route, and extensive protein binding. It's given because of, yes, first-pass metabolism. B is the answer. It's given by the sublingual route because of hepatic first-pass metabolism. Question number 3, Shoini, next slide. What is the clinical term used for angina caused by coronary vasospasm? Classic, myocardial, prinzmetal, unstable. C, prinzmetal angina is the correct answer. All of you have answered it right. The drug that can be used in cyanide poisoning is nitroglycerine, amyl nitrite, lidocaine, nifedipine. Answer is amyl nitrite. It's not A, nitroglycerine, because more specifically, I told you that sodium nitrite or amyl nitrite is given in cyanide poisoning, right? So, yeah, we need to be more specific with the answers. If they wouldn't have given you amyl nitrite, maybe you would have gone with the nitroglycerine with in the answer. But since they have mentioned it amyl nitrite, so or if they would have given you sodium nitrite in the option, so sodium nitrite you would have chosen because that is given more commonly than amyl nitrite. But over here you can go with amyl nitrite. So your answer is B. Next page, Shoini. Which medication is least appropriate for the prevention of angina attacks? Least appropriate for the prevention. Prevention means now you need to consider that drug which is given for the prophylaxis, for prevention of further attacks. ACE inhibitor, metoprolol, verapamil, long-acting nitrates. Which is the one? Answer is A, ACE inhibitor. This is the correct answer. Which medication is the least appropriate for the prevention of angina attacks? ACE inhibitor, right? Because ACE inhibitor has a more profound role in hypertension. And obviously, when you're going to study hypertension, that is the most prominent drug. Isosorbide dinitrate decreases preload more than afterload, right? Isosorbide dinitrate decreases preload more than afterload. Predominant vasodilators action of nitrate is due to the reason that A, B, C, or D. So the answer is it's B. Veins express larger quantity of enzymes that generate nitric oxide from nitrates, right? This is the answer, B. They are asking you that isosorbide dinitrate, it decreases the preload more than the afterload, right? And what is the reason that prominent vasodilator and of prominent vasodilator action of nitrate is due to the reason that now they are selectively concentrated in veins? This is not a correct statement, because they also go to veins and they also go to arteries. I did tell you that they go to all type of blood vessels, right? Veins express larger quantity of enzymes that generate NO from nitrates. I also mentioned this, that it will go to both of them. It will go to arteries, it will go to veins. But the enzyme which is responsible for denitrating nitrite and releasing that nitric oxide is more in veins. That is why the profound action is on veins. Vein smooth muscle has a greater capacity to relax. They have a greater capacity to relax. I mean, arteries have also, this is true that veins is known as a capacitance vessel because it has a large lumen, whereas arteries are known as resistance vessels. But this is not the reason behind why isosorbide nitrate is decreasing more preload than afterload. The reason is that veins have more of that enzyme, which gives free radical, free nitric oxide. Okay, so answer is B. It's not D, all of these. You need to select the most appropriate option, and that is B. So, any next slide. Okay, the treatment of choice for prinzmetal angina is? Yes, so the treatment of choice for prinzmetal angina is nitroglycerin, right? Nitroglycerin GTN is a treatment of choice. I don't know what is making you say D. D is prazosin, which is a alpha blocker, and it is primarily used for the treatment of benign prostatic hyperplasia in the problem of prostate in males. Propanolol is a non-selective beta blocker, so it can't be used for the treatment of prinzmetal angina, right? Why it can't be used? Because you know that it's a non-selective beta blocker, and prinzmetal angina means that there is vasospasm. So when there is vasospasm, it's going to block the beta-2 mediated vasodilation, and alpha-1 mediated vasoconstriction would be there, so you can't give it. Verapamil is also a correct option, right? It's also a correct option, but because for the treatment of vasospastic and prinzmetal and variant angina, long-acting nitrates and calcium channel blockers are preferred. But however, let's consider that if they are talking about of an acute attack, right? So it's whether it's an acute attack of prinzmetal angina, whether it's an acute attack of variant unstable angina, nitroglycerin is going to be the treatment of choice. So we'll go with nitroglycerin because that is a more generic option. A drug not used in prinzmetal angina is, so again, this is the vasospastic angina. Which of the drug is not used? Propanolol, verapamil nitrate, isosorbide dinitrate. Which is not used? Yes, so propranolol is not used. Same reason, it's a beta blocker. It can't be used in the pharyngeal angina or the vasospastic angina. Show any slide, next slide. If there is, yeah, there is one. When nitrates are combined with calcium channel blockers. So now they are saying that you're combining nitrates with calcium channel blockers. Arterial pressure will decrease, heart rate will increase, injection time will decrease, and diastolic volume will increase. What will happen? So when nitrates, now nitrates are the vasodilators, right? Nitrates are the vasodilators, and calcium channel blockers, they decrease the afterload, they decrease the preload as well, and they can also bind to the heart's myocardial cells and decrease the heart rate and force of contractility. So basically, arterial pressure will decrease. Arterial pressure will decrease, heart rate will not increase, heart rate will definitely decrease, ejection time will decrease, no ejection time, it wouldn't affect ejection time, and diastolic volume will increase. So end diastolic volume, it's the amount of blood that remains in the ventricle. So amount of just before the diastole, just before the systole. So just before the systole, the amount of blood which remains in the ventricle, that will not increase. That will not increase, that will rather decrease. Why that will decrease? Because afterload will afterload is going to be decreased. So arterial pressure will decrease means that it is going to dilate the aorta. When it is going to dilate the aorta, so aorta will have more blood. When aorta will have more blood, so more blood will go to the body. Oxygen supply would be improved. When oxygen supply would be improved, so end diastolic volume will not increase. L diastolic volume will also decrease, as end diastolic volume is the amount of the blood which remains in the ventricle before the systole, before that contraction is happening. So we are working on improving the blood supply to the body, and for that the diastolic volume should decrease. Verapamil is contraindicated in all except PSVT with AV block, variant angina, beta adrenergic toxicity, digitalis toxicity. So verapamil is a calcium channel blocker and it is not contraindicated in variant angina, which is vasospastic angina. Because in vasospastic angina, you are meant to give nitrates, long-acting nitrates and calcium channel blockers together. What is PSVT? PSVT stands for paroxysmal supraventricular tachycardia with AV block. AV block means that the conduction of the impulses from the atria to the ventricle is blocked. So in this case, calcium channel blockers would be contraindicated because calcium channel blockers slow down the conduction. So in a situation where already the conduction is blocked, you wouldn't give calcium channel blockers. Why? Because they will further slow down the conduction. Beta adrenergic toxicity, if the body is having toxicity because of beta sympathomimetic drugs, you wouldn't give calcium channel blocker because that would further exaggerate the condition. It will cause more of the bradycardia. Digitalis toxicity, in digitalis toxicity, you do not give calcium channel blockers because again, in digitalis toxicity, the drug of choice, the antidote is Digifab, which is an antibody. Okay, so you do not give calcium channel blockers. It's contraindicated in calcium channel blockers. Sorry, it's contraindicated in this situation. You couldn't give them. It only situation where you give calcium channel blockers is variant angina, vasospastic angina. It's a choice of drug in variant vasospastic angina along with nitrates. I think that's end. Is that end? Yeah. So this is your answer key. If you want to do it later, you can check the answers, and that is it.
Thank you, Kiran, for the presentation. Guys, now we will be opening up the mic. If you have any question, you can put up it. Sure, please help us in unmuting, please. So, Kiran, there is a question in the chat box. Which sort of question comes from this particular chapter in OPRA exam? You can just highlight that.
Yeah, so as I had been mentioning that Adverse effects are very important. Interactions are very important. They can ask you about what is the interaction between calcium channel blocker and what is the interaction between the beta blockers. So like verapamil and beta blockers, they should not be given together because of severe bradycardia. Sildenafil and nitrates like PDE5 inhibitors and nitrates should not be given together because of additive hypotension. What else? They can ask you that if a person is having angina and if a person is having hypertension, what would be the drug of choice? If a person is having hypertension, myocardial infarction, what can be the drug of choice? Beta blockers should not be given in vasospastic angina. Beta blockers should not be given to asthmatic patients. All these are questions. With respect to nitrates, they decrease the preload. What is the mechanism of action of nitrate? That they increase the CGMP, they are vasodilators. What is the dose of nitrate? That is very important. That has been asked in almost every other paper. What is the storage condition of nitrates? What is the expiry of nitrate, right? When should be the nitrates discarded? So yeah, and also with respect to angina, they can give you a question that what happens in unstable angina, what segment is elevated, what segment is depressed, or which is the exercise induced angina, what is the other name of vasospastic angina. That's why I told you that wherever you are being given 2 to 3 names for everything, you should keep in mind every name. Should we give for the most common drug-drug interactions? Like now, guys, see, this is a master class, right? This is not a complete class. Usually, what angina I have covered right now in 1.5 hours, I do not cover that in 1.5 hours. That takes around 3 hours, right? 2 classes approximately. So in that, obviously, the majority of the interactions are given in detail. Should we go for the most common? Yes, you can go for the most common drug interactions because whatever is mentioned in the presentation, you are provided with the most common interactions. Can you please tell us format of OPRA exam? So for format of OPRA exam, I think that is better explained by Shoini. The format of OPRA exam, that how many questions and what is the ratio. But for that, we do conduct another presentation as well, in which we completely discuss.
I'll just quickly highlight. So it's now, as we transit from the KAPS pattern to the OPRA pattern, right, you will have only one paper. Okay, 120 questions you will be getting, out of which around 11 to 12% wherein you will not get any marks. Those will be acting as a demo question in between. And 2.5 hours of the examination will be there. And it is majorly from all the, main topics like your biomedicine, then pharmacokinetics, pharmacodynamics, and then we have the therapeutics. This time therapeutics is having the majority of the weightage, which is around 45%. So yeah, overall, in a nutshell, when we conduct the classes, we keep the APC guideline in mind, and we deliver the batches accordingly. I'm not sure about the username. It is saying MA. When are the OPRA classes starting? We are already running with the batches. You can surely get in touch with us, and we will be able to help you out further.
When are the okay? That's your
new
question.
batch also. We will be able to help you out with the timeline in it. See, the way we deliver in academically, there are 2 modes of delivery. One is with the live class presentation, wherein you get to learn alongside with the faculty's guidance in class. That is one way of delivery. With the crash course version, you get the recorded classes. So that is already inbuilt in-house. So if you join in that particular version, it will be guided to you.
Okay, so there's one question which I've just seen, that what about nebivolol, as it doesn't mask, so it can be given. So see, with the nebivolol, it's a selective beta-1 blocker, and it has less effect on beta-2 receptors, right? So again, it can mask the symptoms, but obviously, as compared to other drugs, it's safer. So better to be safe than sorry. We generally avoid beta blockers in diabetics. But it is, so now the doctor can assess the risk versus benefit ratio and give the drug according to that situation.
Okay, there is one question from Sujan. At which part we have to focus more for the OPRA exam? That goes to therapeutics portion. because the most maximum weightage is 45% that is given to the therapeutics. So we have to be really well versed with the therapeutics portion.
And for being well versed for therapeutics, you need to have your pharmacology in hand in hand, right? Because what is therapeutics? Therapeutics is the application of what you're studying. Now, if it's the same thing, like what drug needs to be given if a person has hypertension and angina, if he has hypertension and myocardial infarction. So majority of the questions of the therapeutic are derived from cardiovascular system. And of course, ANS and CNS, these are the major parts. But for this, you need to be well versed with your systems.
Okay. Any other question? Also on the screen, you can see that we have recently launched our study abroad program. You can scan the QR code and join our channels for the updated information. Also, I will take you to our WhatsApp channel. You can again scan this particular QR code and join the WhatsApp channel for the latest updates.
Ma'am, it has been see, it has been 5 years, Farhat, you have been graduated, which is not a lot of time, I would say. Now you need to know that where are you actually standing. If you have 2 kids and you do not have time at all, I would say take the 4 months course, right? If you do not have time at all, and I would say then go for a 4 months course, right? Because during that you have complete time, the lectures are very elaborative, you have a Discord platform to get in touch with the teachers. But if you think that if you have basis somehow, or you can manage, then you can go through the crash course. But if you think that no, I have forgotten everything and I do not have time to study at all, then go with the 4 months course.
Yeah, just to add with that, when you are in live class, you will get to interact with your classmates as well as the faculty will be present. So it is more, inclined and in line with the preparation in a shorter time. Dr. Sabha, regarding the fee structure, team will get in touch with you and help you out. Chalendra, yes, it will help you to work in pharmaceutical industry. Okay, so Jan, to answer your question, what are the steps to be followed to register as pharmacist in Australia and Ireland? Again, I'll just give you a general guideline because, for every exam, you have to give your candidature to the particular council to validate whether you are an eligible candidate or not. So in that case, we will start with the initial skill assessment, followed by the English proficiency examination, that is mandatory. Then your OPRA examination or the PSI examination followed. Then we can go ahead with the UI visa. These are the basic steps.
Farhat, you do not need to purchase any books if you're getting enrolled with Academically. The material provided by Academically is already too much. So if you're going through that and if you're taking the lectures properly, and let's say you're noting the important pointers which your teachers are telling you during the class, then it's more than enough. Then you'll analyze that still it's a lot to cover.
And also all the material that we will be providing is completely, based on the AMH standard that is religiously followed with the Australian work culture. Any other question? Validity of this skill assessment, there is no expiry to it. You can write the examination. Last time, usually we conduct it over the afternoon time slot. From the Australian standpoint, it will be from 8 p.m. to 10 p.m. But sometimes, based on the faculty's availability, we do make some changes as well. But usually on the afternoon slot of Indian time. OPRA examination result is valid for 3 years. Skill assessment is different. Yes, without the skill assessment, you won't be able to sit for the examination. From wherever you are taking, be it for the New Zealand, be it for the Australia, you have to complete the skill assessment first. Because that particular council will assess all your documents, the degree certificate, and give you a positive candidature result. Manoj, you don't have to write the examination. You can just, revalidate your result. Smear, how much study time is required to clear OPRA? Completely based on your knowledge skill, I would say. But if you are associated with Academically, it will, even if you are spending, 3 hours, including your live class for 2 hours plus, some time at your end, you will be well versed before the examination time. But again, having said that, it is expected that the learner should practice at their end. There should not be gap.